Okay, I'll begin the presentation. Thank you for completing the poll. I have no relevant financial relationships with any ineligible or eligible company, so no commercial influence to this presentation. What I'll talk about today are three growth issues in neonatology. The first one, extrauterine growth restriction. The second one are preterm infants programmed to be obese and hypertensive, and body fat at term age. And then I'll lead you through the evaluation of 10 preterm infant growth patterns. So you've already seen the poll. Thank you for completing that. Let's talk first about extrauterine growth restriction, or EUGR. EUGR is a very popular term in the published literature about preterm infants. And you can see that with a bit of an exception here, there's been pretty well an exponential growth in this topic in the published literature. It's usually defined as less than the 10th or less than the 3rd percentile at around discharge, or 36 to 40 weeks. And it's considered a neurodevelopmental indicator in the published papers. And here are a couple quotes from recent papers that were just published within the last year, that EUGR is described as being, first of all, a common complication of preterm birth. And another paper said, as many have said in the past, that EUGR is associated with poor cognitive development outcome. That's the wording from that paper. So they assume that EUGR is a problem, but when I look at their papers, they actually didn't cite any evidence that having a weight less than around the 10th percentile around discharge is associated with poor development. But it is a concern because I propose to you there are 5 reasons why EUGR is actually not a useful indicator. First of all, it is not predictive of poor outcomes. Number 2, it ignores the normal postnatal weight loss that places infants lower on growth charts. Number 3, it's based on arbitrary cutoffs. Number 4, it's without consideration of the infant's genetic potential and where they should be placing on a growth chart. And number 5, it doesn't consider the other growth assessments such as head or length. So let's talk about point number 1, about is it predictive of poor outcomes? Here are 7 papers that have been published over the years that have assessed how well having a weight below the 3rd or the 10th, or one of the papers looked at the 7th. We looked at continuous percentiles. Do any of these, having a weight below these points, have a predictive ability with cognitive outcomes? Most of those studies have looked at Bailey scores. Our paper that was published a couple years ago now, we looked at IQ scores, which are a better measure because IQ is measuring more what we're getting at, with Bailey is looking at well, it's tools that can be used at around 21 months, whereas it can be a real IQ score at age 3. All of these studies found that having a weight below these percentiles does not predict who has a poor developmental outcome. So it is not diagnostically accurate. It's not helpful. Whoops. So let's look at point number 2. That this categorization of EUGR ignores normal postnatal weight loss that places infants lower on growth charts. So this is a study that was published of almost 1,000 of the healthiest of preterm infants. These infants, to be included in the study, couldn't have had any prenatal or postnatal morbidities. They were in units where nutrition was protocolized, so it was probably better than average. And they couldn't have had any important morbidities. And the background curves that are being compared to are my growth curves. And this curve here is the 10th percentile. So let's look at these patterns. The curve in the middle, the darker curve in the middle, is the median or the middle child in each of these weekly cohorts. And the shaded area shows the 25th to the 50th percentile, or the interquartile range. And what you'll notice is the bottom of the shaded area is pretty close to that 10th percentile. So in other words, among these healthiest of preterm infants, after the postnatal weight loss, 25% of them had their weights below the 10th percentile. And I'll remind you too that some of these studies looked at less than the third and found less than the third was not predictive either. So can we even expect this really good growth for most infants? These were the healthiest of the healthy infants. So what aspects of growth are associated with poor cognitive development? And I have a reference at the bottom where we summarized and identified which studies we were referring to. So the poor growth that is associated with poor cognitive development are two kinds of growth. One is the slowest growing infants. You know those babies. They're the ones that we worry about. We just can't get them growing like we'd like to. And also infants who between 8 and 24 months corrected age, so after they've left the NICU, who are smaller than the growth chart curves, that is less than the third percentile. So these are the kids that just can't get up into the curves, the growth chart curves after discharge. And so I propose to you that what is more useful than looking at a 1-point discharge measurement, what's more useful is looking at the growth rate, which can be looked at in terms of growth velocity or just the growth pattern. But also, I think what's most useful clinically is to look at longitudinal growth monitoring to see how the babies are growing. So what does the American Academy of Pediatrics and ESPGHAN have to say? The American Academy of Pediatrics recommends that preterm infants should grow approximately the rate of growth of a normal fetus. ESPGHAN's recommendations that were just published are very similar. The goal is approximating the growth of the healthy fetus at the same postmenstrual age. So I want to emphasize the word approximate that they both used, because if you were even to weigh yourself or any other person, weight is never constant. And so we can't expect that the growth curves that we see of infants should be a perfect curve. There's always going to be variations. And so it's about approximating that rate of growth. In neonatology and also in pediatrics, there tends to be a real concern about children that are smaller, and it might even be instinct. You know, children should grow. And so we worry about the ones where are they growing well enough? But there is a wide range of infant growth patterns that represent appropriate growth. So let's look at some growth patterns together. So first I wanted to show you some growth patterns of, this is weight gain patterns of 23 to 25 weekers that we published now 10 years ago. And what I want you to notice is that the babies start off in the growth percentiles. I'll tell you the background curves here are the data that I used to develop the 2313 growth chart. So they're the meta-analysis curves up to 40 weeks, and then the WHO growth curves. The smoothing isn't shown in this graph. So what you see is that, you know, babies lose weight, and then when the highest proportion of them are below the growth chart curves is around 36 to 38 weeks of gestational or postmenstrual age. And then they start to deviate up to their genetic potential. And you can see, even though some of these were 23 to 25 weekers, some of them were actually plotting after term age up high above the 50th percentile. So there's a real range even among these really little ones. So let's look at these two, appropriate for gestational age babies at birth. So the little boy on the left lost some weight and then started to grow. He actually maintained his weight above the 10th percentile all the way through. His length lagged a bit and then started to grow and then stayed about parallel to approximately around the 10th percentile after that leg. His head circumference was starting to pick up, and after term age, his head was up to the 60th percentile, which is similar to his birth weight percentile. His weight is well below the 60th percentile here. This little girl also lost some weight, and then as she grew, her weight stayed below the 10th percentile. Her length is also in the lower curves, running pretty parallel. Both of them are pretty parallel. And her head is showing some tendency towards the median of the curve by 40 weeks. So how do you evaluate them? Would you evaluate both of these babies the same, or would you say one is doing really well and one is doing really poorly? So my answer is that both of these babies are growing as preterm infants usually grow, and they're actually achieving both the American Academy of Pediatrics and ESPGHAN's goals. So they're growing well. I'm very happy with both of their growth. I'm not at all concerned that her weight is below the 10th percentile because she's growing approximately parallel to the curves. I'm very happy with both of these babies. What about these two small for gestational age babies? Little boy on the left lost some weight and then was growing nicely parallel to the curves. His length is plotting low, but parallel. His head circumference is pretty parallel as well. This little girl didn't really lose weight, lost very little weight, and then started to grow. And actually, her birth weight percentile was the 9th percentile at birth, and she's at about the 12th percentile at 37 weeks. So she actually exceeded her birth weight percentile. Her length is approximately parallel to the curves. Her head circumference is showing some catch up, that she's actually around the 55 percentile by 37 weeks. So my question is the same for this pair of babies. Would you rate them both as doing well? Do you think one is doing well and one poorly, or both poorly? What is your assessment? My assessment is that both of these babies are growing as preterm babies grow, and they're growing well. Now, the baby on the right grew faster than the intrauterine rates because she overcame the early postnatal weight loss and exceeded her birth weight percentile. Is this what we should expect of all babies? So what is your assessment? I actually think that, because she was growth restricted, she had potential to grow faster than we expect most AGA babies. And yet he's probably just genetically small, and he's growing in a pattern that looks very normal to me. There's actually an Australian paper, the reference is shown here, where they had documented that it is in their data, SGA babies were 4 times more likely to regain their birth weight percentile by 40 weeks compared to AGA babies. In our data, it was 24 times. So SGA babies are more likely to regain their birth weight percentiles, but it's still kind of a rare occurrence. It's not the majority of SGA babies. Now, if you were using that 10th percentile or 3rd percentile criterion, this little guy would be considered growth failing, but I think he's growing really, really well. We can ignore that criterion. It's not helpful. So next is the question, and this is what I've been working on for the past couple years. are preterm SGA infants programmed to be obese and hypertensive? And where this is coming from is the Barker hypothesis, or it's sometimes also referred to the DOHAD hypothesis, which stands for developmental origins of health and disease. It's also sometimes called the thrifty gene hypothesis. And the idea is that if you're born small and due to restricted growth in utero, then once you are fed better, you will become obese because you have changed your genes, and so that you become obese. So let's look at the data and see what we can see. So this is the data for body mass index. And if you look at, you can see that we found 20 studies that looked at body mass index between SGA births and non-SGA births. We looked for every study we could find. We even searched the reference lists of the studies we located in our broad literature search. And you'll see when you look at the effect size here that it is right on the middle. It's on the central tendency of no difference for blood pressure between babies who were SGA versus non-SGA. And you can see from the effect size that it's almost zero, almost exactly equals to zero. So what we concluded from this is that SGA babies are not at risk of higher blood pressure. And we were able to publish this paper this year. The reference number for PubMed ID number is at the bottom of the screen. So other work that we're working on now, it's not yet published. I hope to have it published shortly, is we're looking at later body size and body composition for SGA preterm infants. So this data is the body mass index. So according to the Barker hypothesis, because SGA were small at birth, they should have a higher body mass index later in life. And yet what we found was that SGA infants had a smaller body mass index compared to the non-SGA infants. And it was lower by 2/3 of a BMI unit. You can see that result down here, that the result is not higher for SGA, it's on the other side. And the confidence interval shows that this was statistically significant as well. So the hypothesis also says that if you're small for gestational age, you will put on more body fat and you will have more visceral or truncal fat as well. And so what did the systematic review reveal? And you can see that there's no difference in percent body fat between those born SGA versus not SGA. In fact, it was a little bit lower, not statistically significant, but a little bit lower among those who were SGA. It was not higher for SGA, it was higher for the non-SGA. And in terms of truncal body fat, the same result again, it was a little bit lower among those that were born SGA. You can see we included the ages of the participants in the studies because people might be concerned that you wouldn't see the difference in childhood, you'd only see it in adulthood. And you can see that the percent body fat results from all the studies suggested no significant difference. And the same for the truncal fat. When the bars, the horizontal bar crosses one, it's not significant, or the zero, it's a non-significant difference. So size of birth is actually a clue for how babies might grow. But there are a lot of misunderstandings about the categorization of SGA, AGA, and LGA. The categories are arbitrary and they can be wrong. And here's a quote from a consensus-based definition on growth restriction in the newborn. It was run out of New Zealand, and they invited people from around the world to be involved in a Delphi process. I was pleased to be involved. And one of their conclusions was that infants with birth weights less than the 10th percentile may not be growth restricted, and infants with birth weights above the 10th percentile can be growth restricted. And I think we forget this. Sometimes we believe that the categorization as SGA is important, but it can be wrong. And pregnancy factors can alter growth. So infants can be misclassified at birth, and their size at birth might not fit with their genetic potential. And so that can change over time. Their growth can change from where they started at birth. So what do you think of this little girl? So she was AGA. She was born at around the 60th percentile for weight. She took a while to start growing, and then she was growing, and she reachieved her birth weight percentile by 40 weeks. Her length started up at around the 60th percentile and stayed pretty high in the curves. And her head circumference was up over the 90th and then returned over the 90th by 39 weeks. So what do you think of her? Do you think she's gained too much weight? She's in the upper percentile, she's AGA, and she regained her birth weight percentile. What do you think? So a little more information about her. Her parents were tall, and she was growth restricted in utero. So if she was growth restricted, her weight is actually smaller than you would expect. So in my assessment, she's growing well, and she's growing to her genetic potential. It is rare for non-SGA babies to regain their birth weight percentile, but it does occur occasionally. And in her case, it occurred because she was growth restricted, and she's catching up. So sometimes we tend to think of LGA and SGA as being not normal and AGA as being normal, but it's normal to have people that are in every category across that range. So it can be normal to be SGA if your genetic potential is to be small, and it can be normal to be LGA if your genetic potential is to be big. So I would not cut back on her nutrition. I think she's growing perfectly for her. Now here are two LGA babies, and I'll give you some information about them. The one on the left is a healthy LGA baby. The one on the right, his mother had diabetes during pregnancy and poorly controlled diabetes. So let's look at the little boy first. So he, by definition, his weight is above the 90th percentile. He lost some weight initially, and then he's growing well. He did not regain his birth weight percentile. He's at about the 70th, and his birth weight was above the 90th. So he's still 20 points below. And he's growing quite parallel, maybe a little bit of greater than parallel here, but just a little. His length stayed in the upper percentiles all the way along. He did have a leg, but he's growing roughly parallel. His head circumference had a bit of a leg, and then he was doing some catch up so that his head circumference was similar to his birth head circumference percentile. This little boy kind of kept falling away from the growth curves. He wasn't growing parallel. He might be growing parallel here in the last couple weeks here, but before that, he's been falling off the curves. His length started at about the 40th, and it's roughly parallel, not too concerning at all. His head circumference is approximately parallel. So what do you think of these babies' growth? Are you concerned about one and not the other? So in my opinion, they're both growing well, and their genetic potentials differ. This little boy had some excess fat and glycogen at birth, and we wouldn't expect him to maintain those excesses after birth because he doesn't have the placenta giving him those high sugars anymore. So I actually consider this to be fine growth. He's ending up where we see a lot of preterm babies after postnatal weight loss, and his elevated weight here was artificial at birth. His length and head circumference look like the patterns of an ordinary AGA baby, which he should have been. He had some excess weight here that put him in that category. But this little boy was LGA for all three parameters, and he's grown approximately parallel for his all three growth parameters. His head caught up a little, which we often see. So I think both of these babies are doing well. I would keep their nutrition as per the infant recommendations. So some guidance about growth potentials and what we should expect. First of all, we never really know a baby's genetic potential. You can look at the pattern and that gives you some real clues. You can look at parental heights and that gives you some clues. But you probably, like me, know a family or two where one child's growth is not exactly like the rest of the family. And, it could be that one of the parents has passed on some taller or shorter genes without it affecting their own height, or a combination of both parents' genes has given a different pattern of growth to the child. So parental heights can give a clue, but they're not always the perfect answer. And then when you set your growth expectations, consider any difficulties the babies experienced before or after birth. So if they've had a severe interventricular hemorrhage, that can alter their growth, and that's not readily modifiable. So we need to perhaps change our expectations a little bit if a baby's had a lot of morbidities. And I suggest to you that when you're describing growth, to avoid the word failure, because that word is a label that can stick, and it's a very negative word. A better word is the word faltering. And the new ESPGHAN guidelines that were just published doesn't use the word failure. They use the word faltering, which is really nice to see. So what does poor growth look like? I've just shown you 7 patterns of growth where I considered the growth to be very good growth. So what does poor growth look like? So look at this baby. So he was born SGA and he was small for all 3 parameters. And then his weight and his length have been falling off the growth curves. They are not maintaining parallel. His head is maintaining parallel, but the other 2 are not. What do you think of his growth? What would you think if you were looking at his growth in your unit? So he needs further examination. So we've taken a careful examination of his growth pattern. So now we need to look at his nutrition history. Has he been one of those babies that just didn't tolerate nutrition well? Is that the reason? Has he had some terrible morbidities that have contributed? And if you can't attribute his poor growth to some of these factors, then he probably needs a genetic or an endocrine workup, because he may have some kind of disorder that the parents may need some help. And also then you might have more realistic expectations for him once you have a diagnosis. So here's a little guy. He was born around the 60th percentile for weight. His length and head circumference were just below the 50th. And he did fine in utero, in the NICU. But after discharge, his weight is zooming upwards. We don't have length and head circumference measurements. So his mother had diabetes, which can explain why he fell off the curves a little bit here. But this is kind of high weight gain after discharge. What do you think of this? So it looks to me like the parents are trying very hard to keep up a rapid growth rate. So if you have an opportunity with parents like this to talk with them, it could be good to discuss feeding and satiety cues. So they're really paying attention to his signals that he is giving them. So I think the needs for clinical care and research are different. And I see that in, what we talk about in NICUs and between colleagues versus what gets published in research. And for clinical care, I suggest to you that what we really need is for you to assess each baby individually and look at their patterns of weight, length, and head circumference growth. For research, you do need to quantify growth. And so what I suggest, and I have references below for papers where I've made these suggestions, is that first of all, if you're going to be calling it growth, it would be better to exclude that postnatal weight loss phase and therefore begin your growth assessments at the nadir or at day 7. And then you could use either growth velocity calculations or changes in z-scores. And I encourage that the term EUGR not be used because it's actually not helpful, and it makes people think that all preterm infants, or a good portion of them, are growth failing, and some are faltering, but failure isn't a uniform problem. So let's go over the poll answers about what I think the answers should be. So for the first question, most preterm infants are growth failing by discharge. I believe that that is false. Question number 2, preterm infant growth expectations vary by the prenatal environment, birth size, genetic potential, and NICU course. And I think that's true. Number 3, infants with growth restriction in utero have different growth expectations than those without growth restriction. And I think that's true. Number 4, most preterm infants should regain their birth percentile by 40 weeks postmenstrual age. I think that's false. And preterm SGA infants are programmed to become overweight and have hypertension in later life. And our recent work has shown that that one is false. I want to invite you all to join SONG, which is the Society of Neonatal Nutrition, Gut, and Growth. The address to join is here. The advantages are that we list conferences and we also list guidelines for nutrition and gut and growth health for preterm infants. And we rate those guidelines whether they are consensus-based versus evidence-based. So just to let you know how much confidence you can have in those guidelines. So one other topic that should have been before I went over the survey, but the question is, should I worry about preterm infant body fat percent at 40 weeks? So this is a common concern. And you can see from another look at how many papers have published on this topic that it's growing exponentially in the last few years about preterm infants. So people are very concerned about this topic. So let's look at the data. So what I'm showing you here are 2 graphs from a review that looked for all the papers they could find on preterm infant body composition. And I'm showing you graphs on percent body fat here. We have preterm infants on the left and term infants on the right. And what has caused a lot of concern in neonatology over the years is the comparison at 40 weeks. So when we look at 40 weeks for preterm infants, you can see that their average percent body fat is 16%. When we look at term infants at 40 weeks, so at the time of their birth, you can see that their percent body fat is 11%. And this has caused a lot of anxiety, and people have said that preterm infants are going to be fat as a result. But I think what we really need to do is to look at what happens, because babies do gain percent body fat in their first few months of life, and preterm infants continue to gain percent body fat as well. But what we really need to do is compare, and this is at 52 weeks post-menstrual age, or 12 weeks after 40 weeks, so 3 months. And you can see that the preterm infant average percent body fat at that age is 24%, and the term infant percent body fat at that same age is 25%. So the difference is gone, and it might even be going a little bit the other way. And this is percent body fat, so it considers how much the fat component is relative to the whole body. So I encourage you to have a look at this paper. If you want a systematic review to do, they didn't do a complete systematic review, so it's still a topic that needs to be done again. Plus, there are likely more studies to include, so this will be a good project if you're interested in one. So what I conclude looking at those graphs is that gaining additional body fat postnatally appears to be a temporary event. And I think it's a temporary postnatal thing. It happens to preterm infants, it happens to term infants, it just happens earlier for preterm infants. So I recommend that you not be concerned about that higher percent body fat than term infants at 40 weeks. So my conclusions for you, and then I'm interested to hear about the challenges and successes in your units with growth assessment. So my recommendations are to aim to meet nutritional needs for all infants, aim for growth that is approximately parallel to growth chart curves and accept deviations when it makes sense. And always remember biological variation. It's normal to see a range of sizes and a range of growth rates. So I will stop sharing, and Natasha will have put the results into the chat, and I'm going to copy them down. Oh, great. Has the percentages this time. That's wonderful. That's really helpful. Okay. Great. So I will open the floor to everyone. I want to hear from you. I value the work you do every day. So please turn on your cameras and join the discussion. What could I do to help you? Okay, I see there's a question here. I often hear about pediatricians keeping babies on high calorie feeds until they hit the curve, usually the WHO. How would you recommend providing information to peds at time of discharge on when to decrease calories? I don't know exactly what is meant by hit the curve, but maybe they're talking about getting above the 3rd percentile. And, as a dietitian, I don't like emphasizing calories over any other aspect of nutrition. Calories are just one aspect. And I know that often when pediatricians say calories, they actually mean nutrition. So I would wonder, what they are actually giving. And I would encourage to look at the whole picture, and if the baby is well below the curves, additional nutrition might be highly justified. Yeah, I would want to assess the whole baby rather than having a blanket approach emphasizing calories. Another question was, when would you change to the WHO curve for a preterm baby? So my growth chart goes up to 50 weeks or 2 months post-term. And I think what's best between 40 and 50 weeks is to plot on both if you're seeing babies in that time, because you'll need to go onto the WHO curves after 2 months. So my chart doesn't fit the curves until 2 months. So sometimes it can be helpful to plot on both just for that overlapping time. So any questions? I can keep going with the chat, but I'd be very interested if any of you want to ask any questions. Another question, is the goal of infants to regain birth weight by day of life 10 to 14? Is there a percent weight loss of infants after birth that is concerning? In my experience, I worked for 18 years in a level 3 NICU, is that babies are going to do what they're going to do. And a lot of it depends on the fluid management in those early weeks, but it also depends on nutrition. It also depends if they were growth restricted or come from a mother who had diabetes. Like there are a lot of things that influence it. And then some babies are just unwell and they struggle and take a little longer to regain their birth weight. I haven't seen data that separate from any morbidities the babies have experienced, that getting them to regain faster is better. So I think the best thing is to monitor the individual and make sure the nutrition is good, that the nutrition is being delivered, and that there aren't any barriers to getting that really good nutrition into the baby. Next one, should Z-score trends then be followed by nadir or day 7 anthropometrics? I suggest that you use the nadir or day 7 as a comparison, not the birth weight. And there's another question. I'm understanding, and a preterm infant born less than the 3rd percentile, if she remains less than the 3rd, but is tracking parallel, would be acceptable. Yes. Yeah, it's the parallel growth. If you look at the American Academy and SPGAN's guidelines, they don't talk about exceeding any specific percentile. They talk about parallel growth or approximating the growth rate. So have a look at that and be reassured that that's what we need to aim for. Is there a reference you recommend for assessing whether parents are taller versus shorter than typical? No, I wouldn't. I think that because parental height is only somewhat predictive, it's quite, but not perfectly predictive of a child's size, that I wouldn't get numerical about it. And I would just go by, your assessment of the parents, just, subjective. Are they tall or are they petite? And just to give you a clue. And I mean, if you're doing research, then mid-parental height can be used with a formula where you alter it for girls versus boys. But for clinical care, I suggest you just have a look at the parents. I've had parents that were both very petite ask me if their child's going to be tall. And, if the genetics on both sides of the family are to be petite, the chances are the child will be as well. But I'm getting tired of talking. Would some of you come on and ask a question? Here's a good question. Would you expect a slightly different rate of growth for a baby on breast milk versus formula? And I think Sharon Growargo made the most important point about breast versus bottle feeding is that when an infant is bottle fed, the amount delivered to the baby might not be exactly what the baby wants. Whereas when you're breastfeeding, you cannot force feed a breastfeeding baby. So I don't think that the real difference is between what milk that's given. I think it's the ability to actually force feed, encourage that baby to finish the bottle. Formula is expensive. You've all heard it, I'm sure. I think we need to not look down on formula too badly. The majority of parents in North America do not breastfeed to 9 to 12 months so that they can go on to cow's milk and not give any formula. So we need to support parents that formula is okay. Majority use it, and we don't want them going to the homemade formulas or inadequate things. So formula is much better. For a non-breastfed baby, formula is the best choice. So, here's a really, really good question about catch up. When would an infant be considered caught up when they return to their intrauterine growth rates? Yeah, I don't love the term catch up because people like to quantify it numerically. And, if a baby is genetically small, then we don't want them to catch up to any artificial means. If they're growth restricted, they should catch up to their genetic potential, but we don't know where that is. So I think the best thing is to feed a baby to nutrition recommendations, and then when they are nipple feeding, allow them to dictate the amounts. And then we look at the growth, and the growth will show us the genetic potential of the child. And I know we want to know what it is, but it's best for the child to tell us. Yes, another question. If a preterm infant is born below the 3rd percentile and remains below the 3rd percentile, but appears to be following a trend, is this acceptable, or would you push extra nutrition? I would assess whether the nutrition being provided is within the recommended amounts, or is the baby being underfed? And if the nutrition is within recommended amounts, I would accept it. 3% of the population should be less than the 3rd percentile. So it's rare, but it does occur. So if a baby's growing nicely, when you said following a trend, I assume that means parallel to the growth chart curves. I wouldn't push. I don't believe in pushing nutrition. Before they're nipple feeding, we are deciding how much they get, but make sure that the nutrition is within recommended amounts and being absorbed. And then I would have confidence that the baby's doing exactly what he or she is supposed to do. What are some of the challenges you have in your unit? Is that a question coming? I hope. Yes, I recommend using birth weight to calculate nutrition intake until the baby regains birth weight. Samantha has her hand up. Yes, please, Samantha. You're muted still. Oh, no, you're not, I think. Do you have a question, Samantha? Please interrupt, Samantha, if you can get through. How long to stay on fortification? That's a complicated question. I mean, you need to look at the growth patterns and how well the baby is able to take, or that's after discharge fortification. How well is the baby self-feeding? Those kind of questions. And how tiny was the baby at birth? Does the baby need the extra minerals for bones? Oh, Beth, I see your hands up. Please ask a question, and you are muted. Oh, excellent.
Hi.
Hi.
I have a question about our like chronically fluid overloaded babies and how to kind of assess
Estimate a
dry
weight.
weight. Yeah, like an estimated weight and how much to like increase weekly, or how do we
Tough one. Yeah, because
how do we know what we're doing?
It's a judgment call, you know. It's a tough one. You have to use it. Yeah, you have to guess at a number and increase it as a guess. Yeah, unfortunately, you know, hopefully they can manage the fluid so that you can get a weight to use. But yeah, it's a guess. I don't have any answers there, sorry.
Okay. I'll just say from kind of the way I've approached it in the past is like if we are using a estimated dry weight of, let's say like I don't know, 1.8 kilos,
Okay.
and it's been a week or 2 weeks and we're still using that same estimated dry weight. Like in the past I've recommended like, and this is kind of based on like average PD tools, weekly weight gains, weight gain averages and stuff, like increasing that by 100 to 200 grams a week to mimic, I guess, and, you know, adequate growth.
Yeah, if nutrition is good, and yeah, I would even get out a growth chart and plot the two numbers, and you know where you or where you thought the baby was, and then if it was parallel, then that would give you an estimate for weight for later. Yeah, for the next time.
Okay,
yeah,
thank you.
That's a good plan. I think we have another 5 minutes. You have 5 minutes to ask questions. What are the challenges in your units? Are all your NEOs on board with really good monitoring? Okay, we might as well wind it up. Thank you for your time and attention, and for answering the survey. I appreciate it. Oh, there are 2 hands up. Great. Jessica, please go ahead.
Hi, can you hear me?
Yes.
Okay, good. I'm just wondering about babies that are IUGR or SGA. Do you usually give them higher calories from the beginning to kind of catch up with an expected need for catch up, or would you still give them the appropriate calories for their gestation?
Yeah, we don't have guidelines from any guideline group to give higher calories for growth restriction. So what I would do is I would aim for, you know, as Dr. Growargo said this morning, aim for the upper end. I think the case she was talking about was use the lower end. I would aim for the upper end of the recommendations and see how the baby does. It's always nice when the baby goes on to nipple feeds, because then the child can demand and you can feel confident that they're getting the right amount of energy. And yeah, so that's what I would recommend, is stay within the recommended guidelines. Yes, Emily, you're next.
We started looking at adding the malnutrition tool into our NICU, and having a lot of issues trying to figure out how to kind of use it as, like you talked about, each baby, depending on what's happening with them, it takes them a little bit longer to sometimes regain birth weight. And then that would stick them in more of that moderate, severe malnutrition. So I was wondering, do you use the malnutrition? Like, do you assess for malnutrition? Or
Yeah,
what would
so
you have?
I'm not working clinically now. I just do research, but I guess the way I see the malnutrition guidelines is they can be a useful tool when you need to make a point that actually this child now is in the category of malnourished, so we have to improve things. Other than that, I don't find the label of malnourished useful, you know, unless you're doing a research study or you want to make a point to the team. Other than that, I actually don't find it that helpful. I like to look at each individually and yeah. So I think it's mostly a tool to make a point to the team. So Catherine, your hand is up, please go ahead.
Yeah, it's a little bit associated with that last question, but just I had to step away and you had mentioned something about a 5 or 7 day weight loss nadir. And I was wondering if you could just remind me what you were talking about at that time.
Sure. So about the nadir or day 7 weight is that if you're going to calculate growth, that's a good point to start, because often people will start at birth and they'll talk about the growth rate, often in a derogatory way. But I mean, we have to accept that that baby is going to lose some weight first. And so it's not growth until they're growing. So a good time to start calculating growth is the nadir or day 7.
Okay, that's pretty helpful. Thank you so much.
You're welcome. Okay, we're at 2:15 now, so I think we're going to end. So thank you, everybody. Take care. Good luck working with your babies. I admire the work you do. Keep it up. Take care. Bye.